we patient advocates simply say, hey, it's our data, use our data. A lot of data is not used or is used in a later state, and it simply slows down progress in research. And when you slow down progress in research, you slow down progress in treatments. And for us, patient, it's always about quality of life that needs to be improved. So it's data, it's research, it's treatments, it's quality of life. The end goal is always improve quality of life.
Welcome to EHA Unplugged, the official podcast channel of the European Hematology Association, EHA. I am Isabel Olivera, your host. Today, we'll have the pleasure to have with us Peter Kapitein. Peter Kapitein is a patient advocate at Inspire to Live. Peter's lifelong work centers on one essential question: how can we bridge the gap between what science discovers and what patients really receive? In this episode, we'll explore what meaningful advocacy looks like, how patient voices can shape access to new therapies, and why collaboration across communities is key to improving outcomes. So welcome, Peter. Thank you for being with us today.
Thank you for the invitation, and happy to contribute to the listeners who hopefully can be helped with my stories.
To start off, Peter, you often say that advocacy means connecting people who should already be connected. What inspired you to take on that mission?
Well, that's a good question. People think they are connected, and of course they are connected. I think all researchers, for example, meet with each other on congresses. They meet with doctors, they meet with industry. So people really know to find each other, but finding each other and really working towards a goal that contribute to patients is something different. What we aim for and what we are doing within Inspire to Live is what we bring together the right people. And that sounds very general, but the right people are not always the people that normally meet each other at events like congresses. So we really think about who should meet who. And to give an example, sometimes a fundamental researcher in cancer might be helped by someone who knows a lot about rheumatoid arthritis. And then we bring together these researchers on, for example, DNA repair, on aging and rheumatoid arthritis, because they both probably know things that are of importance for the other one. And this sounds again a little general, but we within Inspire to Live have so many different expertises that we are able to say, but in this situation you should ask her or him to work together with the other people. And then we bring them together and, well, we start initiatives, and quite often, of course not always, but quite often it becomes successful.
We're talking about Inspire to Live. Can you explain what Inspire to Live is?
Yes, in 2010, we started with Inspire to Live, and you could say the reason for that is I was diagnosed with a lymphoma in 2005, had several relapses. I had an autologous stem cell transplantation in 2008. I had 2.5 months later, in September the 3rd, 2008, an allogenic stem cell transplantation. And then I wanted to know who developed these stem cell transplantation, and one of them appeared to be a Dutchman, and I worked with him. His name is Dick van Beckham. I worked with him until his death. Dick died in 2015 when he was 90 years old. And from him, I basically learned how to work with scientists. And, well, as a kind of giving back for all the good treatments based on good science, all the good nurses, doctors I had, I started Inspire to Live. Of course, I first started Alp du Zes, a fundraising initiative. We raised so much money that we could set up very, very good and also expensive research. But in 2009, we thought we are very good in the Netherlands with research. We can do better on implementation. And together with the Dutch Cancer Organization, at that moment, we decided to go international. And because we are good in research, but we will not be able to solve the problem of cancer alone in the Netherlands. For that, we need cooperation. And basically, that's how Inspire to Live started. Formally, 2010, we had our first initiative, our annual congress in 2011. We brought together researchers and clinicians from the United States, Canada, and Europe in one room and started initiatives. That was really a breakthrough. We started projects which were performed by researchers and clinicians from the United States, Canada, and researchers for Europe. That was basically the start. And Inspire to Live is, well, in essence, it's still the same. We bring together the right people, now not only in Europe, North America, but globally around a certain topic. And then we start an initiative. Well, we start lots of initiatives. You could say we're a knowledge broker. A lot of knowledge is inside our organization, but of course we do not have all the knowledge, but we know to find the knowledge. So we are a knowledge broker and a network organization where our professional volunteers work together. Volunteer in the sense that they do not get paid for their work within Inspire to Live. Professionals because they're professional in their research institute or in their hospital or in their company when they work at industry.
Can you give us an example of one project that has been successful in reuniting researchers with patients and that has changed the way things were done?
We brought together researchers from the United States and Europe, 2011, 12, 13, and a small group. I think in total we were 12 people. And out of that came 4 projects with organoids. So these were projects for lung cancer, prostate cancer, for pancreatic cancer, and for colon cancer. 4 projects, on average $6 million each, were started, and they run for 3, 4, sometimes 5 years. And in the end, the result of that was here in the Netherlands. We have it's called a hub for organoids, where organoids are produced and they are used for finding the right treatment. They are used by industry for testing their medicines in phase 1 or phase 2. So you could say it's not that organoids wouldn't have been here without Inspire to Live, but if you ask these researchers, we at least speed up the process of organoids 5 years. That's what we more or less guess. So organoids is one of the big successes of Inspire to Live.
So Inspire to Live connects people, but you don't bring money.
No, we don't fund research. We bring together, start initiatives, we design initiatives, so to say, and then we look together for the right funding.
Who designs the initiative?
From the start, we discuss what needs to be done, how it needs to be done. To give an example, at this moment, we're part of an application for the Cancer Grant Challenge with the last 4 on dark proteomes, which is a very fundamental research. But Ilona and I, 2 patient advocates of Inspire to Live, cooperate with researchers and clinicians from, the Dutch Cancer Institute, but also Dana-Farber, Michigan University, MIT in the US, so a big international consortium. We're in it now, and the moment we get funded, we will continue working together.
You have argued that we often fail to do what we already know works. What do you mean by that?
We do not execute what we already know.
Yeah,
that's a quote from a British scientist, and it really expresses what can be improved. Science is way ahead of the clinical practice, which is normal. First, you have to have the evidence, but the time between the evidence and the implementation in the clinic, that's too long. If you know that a new approach, a new treatment, let's take CAR-T. We know how to do CAR-T, and still we are struggling with implementing it. And of course, in the Netherlands, we have one implementation, and in France a little bit more, and in Germany a little bit more, but we are not executing what we already know. I live because of an allogeneic stem cell transplantation, and I owe my life to that. But I'm an advocate for CAR T because the big advantage of CAR T is that you keep your own immune system. So there will never be rejection because it's your own immune system. And the success rate of CAR T is much higher than the allogenic stem cell transplantation.
In cell therapy, there is also the matter of cost. It's not obvious to translate this into the clinic because it's a very complicated process and it's also very costly. There's so much research to try to make it cheaper and more affordable. Are you importing that?
For EHA, I'm a project manager in the Ascertain program, which is about pricing, cost effectiveness, and reimbursement. And one of the advisors of Ascertain is Julio Delgado, who is a physician in Barcelona, and he produces CAR-Ts, and his price is around 80,000 euros. 80,000 euros is more or less the same as the cost for an allogenic stem cell transplantation. So you see that we can do it more affordable. There is a good project here in the Netherlands, in Groningen and Rotterdam. They are working on producing CAR-Ts in-house in the hospital, which will also make them much more affordable. So I think research is not only finding the best treatment, but also the best affordable treatment. But I also think you should look for how can we make it affordable, not only for the rich Netherlands, Germany, France, but when we talk Europe, also for Romania, Bulgaria, Poland, Hungary, the less rich countries in Europe.
Yes, you're going into what I wanted to ask because EHA has this focus now on borderless hematology. And it wants to emphasize in part that one of the priorities for EHA is equitable access. And of course, many of the new treatments for cancer, like bispecifics and cell therapy like CAR-T, are really expensive. How do you think we can help this get to more people?
I think we should also look to procedures that are less costly, where you make it in-house in the hospitals, which will probably be at least first the academic hospitals. So these are all possibilities. And as we know, CAR-T is one treatment, and then, after, of course, it's a very complicated treatment, and you need a good intensive care unit, etc., etc. But if it's successful, you can go home. So I think we should look for more creative solutions, in-house productions, or go to hospitals like Barcelona. And this is the way we can also bring these innovative cellular and gene therapies to the less rich countries in Europe.
So you also are very interested in ownership of data. That's my data, use my data. What does that mean in practice for you?
We patients, we produce tons of data by simply being diagnosed, the treatments that we go through. We produce a lot of data, which is how a treatment works in my body. This data is filed in repositories. There are two aspects on data: the legal aspect and the ethical aspect. So the legal aspect, if your data is in the hospital, it's still your data and you're allowed to ask for that data and do with it what you want. If your data is from a trial, it's legally owned by industry. But there is also an ethical aspect on that, and that is that this data is extremely important for research and industry to innovate the treatments. We patient advocates simply say, hey, it's our data. Use our data. A lot of data is not used or is used in a later state, and it simply slows down progress in research. And when you slow down progress in research, you slow down progress in treatments. So it's data, it's research, it's treatments, it's quality of life. The end goal is always improve quality of life. It's our data. At least from an ethical perspective, you should share it immediately. So that's why we advocates simply say, hey, it's our data, use our data. For a lot of patients who will not benefit from the latest treatments, it's the only possibility to contribute. And patients want to contribute. Maybe 1 or 2% not, but the great majority wants to contribute to science to improve treatments for the patients that come after them.
So do you think most patients give free access to the data to research?
I wrote an article. It's, almost ready for peer review. And in the article are a couple of references that shows that more than 95% of the patients say, use my data. You don't even have to ask, use my data because I gave it for diagnostics or whatever. So use it. Some patients say, oh, you have to ask permission, but it's basically the legal people. Patients don't talk about privacy. They expect you to deal with data in a proper way. The checks and balances in the use of data are in place. A researcher might make a mistake, that's always possible, but researchers know that if they misuse the data, their career will be damaged. So they don't.
You think there are enough checks and balances to keep, obviously data is anonymized or semi-anonymized?
And if the checks and balances fail, I should say the benefits of immediate sharing are much greater than the damage that can be done when data is misused. So, and that's what I call the hidden cost of saying no. It's not that when you do not use the data or do not share the data, that there are no consequences. The consequences of not sharing is slowing down the progress of research, treatments, quality of life, which simply cost lives.
So looking ahead, what do you think that could be done differently in advocacy to get the treatments quicker to the patients?
Basically, what we need to do is more cooperation between patients, researchers, and clinicians. And I think that's important, that when you want change in healthcare, cooperation between patients, researchers, and clinicians is key. If you go alone as a patient advocate, you will be not successful. If you go alone as a researcher or as a doctor, you will be not successful. Maybe in the end, but you can speed up the process by bringing together science, treatments, and the patients, and then go to the regulators, to the ones who have to approve, who has to fund, etc., etc. I think cooperation is key.
So we go back to the goal of Inspire to Live, which is to put the people who need to be in contact. Finally, if you want our audience to remember one thing, one message of this conversation, what would it be?
I think for the benefit of patients, it's key to cooperate, because if we don't, we lose too much lives, but we have the capacity to change that.
Simple, but really hard to do.
There's a difference between simple and easy. Some things are really simple. It is about cooperation. It is about working with the right people together. That doesn't mean it's easy. The reason why, and always think of why we should do it, the reason why is so important. We're not talking about 10 or 100 or 1,000 patients. We're talking about hundreds of thousands of patients or millions of patients in Europe. And we're talking about tens of millions of patients globally. I mean, what we produce on good treatments in Europe also needs to become available for the lower middle income countries in Africa, in South America, in the Middle East, in Asia. Capacity of helping lower middle income countries, not only the low income countries or the middle income countries in Europe. But our organization is global, so we work with countries like Kenya or Guinea or Armenia. All these countries need our help. And I know EHA for, at least since 2010. I know that it is an organization that has enormous capacities to improve the quality of life of patients in Europe and on a global level as well. It's quite easy to help. The medicines that cured me, I had treatments from 2005 till, let's say 2009. But the medication I got was and is good. So a lot of medication that we can offer these countries are now very cheap. Maybe in my time it was expensive because it was, for example, rituximab was of course on patent, but it's not on patent anymore. So rituximab is now a biosimilar or a generic, which is very affordable. It's also affordable for most, at least for the middle income countries. And there are of course extremely poor countries where it's not affordable, but you can start working on it. You take, for example, like Costa Rica, which is not a rich country.
Because where I come from, by the way.
Okay. Well, I know Costa Rica quite well. But so in Costa Rica, a lot of medicines are affordable. I don't know, but maybe even some patented medicines, but at least the off-patent medicines, and a lot of off-patent medicines are very good. When we have We have more than 30 low and middle income countries. When we asked Ghana, what is your most needed medicine? And we asked it to a physician for breast cancer. And she said, well, Peter, if I could have enough tamoxifen and Herceptin, I can help thousands of women with breast cancer. You can save a lot of lives with existing affordable medicines. And still we use cyclophosphamide treating leukemia and lymphoma patients. Cyclophosphamide is, more than 100 years old. It's well, we call it 10 euros per gallon. It's very affordable, you see. So you can do a lot of good things with affordable medicines. One of the products that this early detection based on a blood draw and then look for proteins, and you can find now 14 different cancer types with a simple blood draw analysis of the data, and then an algorithm runs and it gives you a probability of cancer. Mm-hmm. The price of the algorithm is around $50, $60, $70. Mm-hmm. One of our advocates is a Chinese researcher, and he has two approaches. One is compared to Gallery and Thrive and other projects based on DNA sequencing, which is 11, 12, which is unaffordable. Mm-hmm. His product is $70, $80, $90, which is much more affordable. When you look at the sensitivity and specificity of the DNA sequencing, well, the specificity is not really higher than the only protein. The sensitivity is 58% of the protein tumor marker analysis, where Gallery is, and his own sequencing product, by the way, is above 80, which means the sequencing is better, but unaffordable. So, and he has a beautiful remark. He says, yes, Peter, sushi is better than rice, but when you're hungry, rice will do. And we asked the professors in Nigeria and Kenya, what should we do? And he said, Peter, Ifeoma Okoye, who is a professor in oncology in Nigeria, Peter, the sensitivity in my country at this moment is 0%, because we do not detect anything. So if you come up with a product of 58%, we make quite some progress. And we also ask the ethical question, because, but then we detect it, but then it needs to be, if you find a cancer, you need to treat it. Is it ethical to only detect and maybe not able to treat it because the treatment is not available or is too expensive? And her remark, and that was also the remark of the professor in Kenya, is we need to break through that circle of desperation where patients don't come to the hospital and die in loneliness, or when they come to the hospital, 80% of the patients in these countries come in stage 3, 4 to the hospital, where the only thing that you can do is pain management. Least to have to give them a dignified way of dying. So we have to break through that circle of desperation.
So there are many things that can be done with not that much money, because you can get the message to people that you have to go to the hospital as soon as possible. And the other thing would be to use medicines that are not that expensive, but they're still good.
They're still good. Cyclophosphamide is still good. It's still good. IDA Foundation, which is related to the World Health Organization, and IDA Foundation provides medicines for low and middle income countries, and they have a quality check, so they deliver good quality medicines for the lowest possible price. And we already set it up for Uzbekistan. One of our advocates is he has now got his PhD, and he worked on it in his country, Uzbekistan, who said, what are the most needed medicines that we do not have and need? And the Ministry of Health has budget for these medicines. And then it's basically very simple. It's called NCD Connect, which is basically the supply chain for medicines. And the doctor in Uzbekistan simply says, hey, I have, for example, I have 12 breast cancer patients that need tamoxifen. Well, she orders for 12 patients for 1 year. She pays, gets the medicines delivered, and that's how it's been set up in good and affordable.
So thank you very much, Peter, for being with us today.
Thank you for the invitation, and I really appreciated it, the way we could elaborate on progress in science, treatments, and like I said, the outcome always needs to be a better quality of life. So really, thank you for this.
Thank you to all of you for listening. And if you enjoyed this episode, please like it and subscribe to our channel. Stay tuned for more episodes of EHA Unplugged.